Good morning, and thank you for joining us for today's Genetic webinar entitled Autism and Related Disorders. This series is jointly provided by Texas Children's Hospital in collaboration with Baylor College of Medicine, Texas Health and Human Services, and the University of Texas at Austin, Texas Center for Disability Studies. Support for this presentation comes from the Department of State Health Services. If you are a social worker and would like 1 free hour CEU, this webinar has been approved for 1 hour by the University of Texas at Austin, Office of Professional Development, School of Social Work. The views and opinions expressed during this presentation do not necessarily reflect those. Sorry, guys, the thing keeps wanting to go forward. The views and opinions expressed during the presentation do not necessarily reflect those of Steve Hicks School of Social Work or the University of Texas, nor does it mention of trade names, commercial practices, or organizations imply endorsement by the school or university. We will be saving time for your questions at the end of today's presentation, but you can submit your questions at any time during the presentation using the Q&A box at the bottom of your screen. Today's presenters are Dr. Umanya and Laura Buckner. Dr. Umanya is a bilingual licensed psychologist and board-certified behavioral analyst in the Autism program at Texas Children's Hospital. Just going to do this for now.
Probably. Not getting engaged.
She specializes in the assessment and treatment of children with neurodevelopment differences, including autism and ADHD. Dr. Umanya conducts comprehensive psychological evaluations for children and adolescents using a wide array of standardized assessment tools. In addition to diagnostic services, she provides behavioral intervention for toddlers and children with autism and other developmental differences. Her areas of focus include addressing behaviors of concern, such as anxiety, tantrums, aggression, noncompliance, sleep difficulties, and toileting challenges. Dr. Umanya is committed to delivering culturally responsive care and empowering families with evidence-based strategies tailored to each child's needs. Our second presenter is Laura Buckner. Laura holds bachelor's and master's degrees in education, counseling, and rehabilitation. She is a licensed professional counselor and a certified mentor trainer in person-centered practices, the learning community for person-centered practices. Laura is experienced in educating others about family support, state, local, and federal community resources for people with disabilities and their families, program development, and communication, sharing success stories to impact change. As a family member herself, she specializes and especially appreciates opportunities to work with families and those who serve families. She says her most important degree is her MOM degree, Mom. Having parented a 35-year-old son diagnosed with 3 months of age with a rare disease that includes IDD, autism, and chronic health issues. Laura says he's taught her everything she knows, almost. At this time, I would like to encourage Dr. Umanya to share your slides.
Okay, I think that worked.
Yes.
Okay, perfect. Hello, it's such a pleasure to speak to you all today. I'm Ileana Umanya. As was mentioned, I'm a licensed psychologist within the autism program here at Texas Children. So today I have the pleasure of speaking to you about autism, ADHD, and how they're related, but also how they're different neurodevelopmental disorders. And so when we think of neurodevelopmental disorders, we think of that they typically manifest in early development, often before the child enters school, and they are characterized by developmental deficits or differences in brain processes that produce impairments of personal, social, academic, or occupational functioning. They range from developmental differences from very specific limitations of learning or control of executive functions to global impairments of social skills or intellectual ability. When thinking of what we'll be covering today, we will be going over a brief overview of the key diagnostic features of autism spectrum disorder and also those of attention deficit hyperactivity disorder or ADHD. I'll also describe some areas of symptom overlap in children specifically. We'll also examine common comorbid conditions associated with autism spectrum disorder and ADHD, specifically in pediatric populations, so things like anxiety, learning disabilities, and how these impact clinical presentation and daily functioning as well. We'll also look through briefly some interventions for children with neurodevelopmental differences, including behavioral, educational, and therapeutic supports. So I'll be giving a very brief overview of these in our time together, but I really hope that it is helpful. And so we'll get started with looking through the diagnostic criteria for both autism and ADHD. So when we're looking at autism, there's two main umbrellas. So the first one we think of as what we think of as A criteria. So the DSM refers to it as A criteria and B criteria. So the first one is persistent differences in social communication and social interaction across multiple contexts as manifested by three of the following symptoms. And so children need to have all three of these to be able to kind of move on to the next set of symptoms per se. So the first area is difference in social emotional reciprocity. And so here, this is looking at things like having atypical social approach, difficulties in initiating or engaging in conversation, reducing their maybe reduced sharing of interest or emotions, maybe they're just one-sided, to difficulty with initiating or responding to social interactions. It could also be difficulty moderating tone and tone of voice and things like that. The next area is we're looking at nonverbal communicative behaviors used for social interaction. And so this could be fragmented or not aligned verbal or not verbal communication, difficulty with understanding nonverbal social cues, so things like eye contact, body language, gestures. It could also be a tendency to minimally communicate through nonverbal communications, so those that I just mentioned, and also failing or having difficulties integrating both for social communication purposes. And the third symptom within the first cluster of symptoms is differences in developing, maintaining, and understanding relationships. So this varies really depending on the stage of development, but this could look like difficulties adjusting behavior to suit various social contexts, difficulty sharing imaginative play or engaging in group work activities, difficulties making neurotypical friends, or also an absence of peers. And so that really depends on where the child is developmentally. The next area that we look at is repetitive patterns of behaviors, interest, or activities. And for a child to meet a diagnosis of autism spectrum disorder, they need to meet two of the four following symptoms. So the first is stereotyped or repetitive motor movements, use of objects, or speech. And so this could be for motor movements, things like hand flapping, body rocking, spinning, pacing. For repetitive use of objects, it can be things like lining objects up, piling them up, any repetitive play. And then also for use of speech, it can be repeating or echolalia, scripting from television shows or movies. Then we also look at insistence on sameness, inflexible adherence to routines or ritualized patterns of verbal or nonverbal behavior. And so these could be an interest. This could be things like wanting to have the same maybe food every day or having difficulties changing their routines, wanting things to happen a specific way, being very stuck on a specific item. And one that isn't on here that I missed, and so that's why I was looking at my notes, is they can also have a highly restricted or fixated interest that are abnormal in intensity or focus. So this could be an interest that plays a significant part in a person's identity to a topic that an individual tends to enjoy. And so sometimes these can be things that are developmentally appropriate. So having maybe an interest in Garfield, which has happened here recently for one of my patients, but the level of knowledge about Garfield was a little atypical, or things that maybe aren't age appropriate, which has also happened in the last few weeks, which was for one of my patients, doomsday prepping. And so that was really interesting for an 8-year-old. And so lastly, there's also hyper or hyporeactivity to sensory input. And this could be things like fascination with visual patterns, craving tactile experiences, touching surfaces, smelling them. So any range of differences within the sensory environment. Then when we look at ADHD, so we look at the attention deficit hyperactivity disorder. So we know that with ADHD, we're looking at inattention, hyperactivity, and also impulsivity. So first, we're going to look at the inattentive type. And so here, failing to give close attention to work details, creating careless mistakes in schoolwork, having difficulty sustaining attention in tasks or activities, not seeming to listen when they're spoken to directly, doesn't follow through on instructions, fails to finish schoolwork, chores, or difficulties in the workplace, has difficulty organizing tasks, often avoids or dislikes, or is reluctant to engage in tasks, can be very distracted or can be forgetful. And so here we're looking at 6 or more of the following symptoms for at least 6 months, or 5 or more symptoms if the individual is 17 years old or higher. And then these are negatively impacting social, academic, and or occupational activities. In regards to hyperactivity and impulsivity, it's also 6 of the following and or 5 of the following if the individual is 17 years or older. So here we're looking at fidgeting or tapping in the hands or feet, squirming in seats, often leaving seats in different situations, or running about or climbing in situations where it's not appropriate. And this could be for adults or adolescents, that feeling of restlessness, often unable to play or engage in leisure activities quietly, feeling on the go or driven by a motor. Talking excessively, blurting out an answer before a question has been completed, difficulty waiting for turns, and often interrupting others as well. So these would have to have been present before age 12, and they have to be present in 2 or more settings, so at home, at work, with friends, and other activities. There also has to be clear evidence that symptoms interfere with the quality of those of life within those settings as well. And there is the hyperactive, hyperactive and impulsive type of ADHD, inattentive type, and also the combined type ADHD. Now, when we're looking at symptom overlap within autism and ADHD, what we can see is difficulties with working memory, with the executive functions. So this could be difficulties with working memory, with planning, with organization, with inhibition as well, which can be common in both of the diagnoses. Children can also struggle with task completion, with transitions, and with emotional regulation. When we're looking at attention and distractibility, yes, it's it's in the name of ADHD, and that is core and persistent across settings for children with ADHD. But children with autism spectrum disorder can also have attention issues, and these may seem more situational or related to maybe sensory interest or their restricted interest, or could also seem inattentive due to maybe a lessened degree of social interest as well. When we're looking at emotional dysregulation, this could look like high reactivity, it could look like mood swings, poor frustration tolerance, and this can be present in both groups of individuals. Emotional outbursts can be due to sensory overwhelm for children on the autism spectrum, or also poor impulse control for those with ADHD. As far as social difficulties go, it is very core to the autism spectrum diagnosis. And so individuals have difficulties interpreting social cues, reduced reciprocal interactions. They can appear socially disinterested, but also children with ADHD may also have social difficulties as they can be impulsive and interrupt. They can miss social cues due to inattention, or also have some difficulty socially given their behavior and how that is taken by peers as well. As far as sensory processing goes, again, it's core in autism and part of the DSM-5 criteria, so hyper or hyporeactivity to sensory input, but it can also be frequently described in children with ADHD, so maybe they're becoming more distracted due to noise, or it's something that might help calm some of those motor on-the-go type behaviors. And hyperactivity and impulsivity. Now, this is also core to ADHD again, but it can also appear in autism, particularly in early childhood. In autism, it can also be appear more stereotyped or driven by sensory needs as well. So when we're looking at co-occurring conditions, what we kind of find is that, so I have a longer Venn diagram here. I'm not just trying to get it in circles and it just wasn't working. So with many children with autism spectrum disorder and or attention deficit or ADHD can have additional diagnosis. In fact, 74% of children with autism and 78% of those with ADHD can have more than one co-occurring condition. So the first one is anxiety disorders. In both groups, about 40% of children with autism or ADHD also present with some type of anxiety. Generalized anxiety, social anxiety, or specific phobias are typically among the most common. And so these high rates really show the need to screen both sets of patients or individuals for this type of other comorbid condition as well. We're also seeing that academic learning challenges, whether this is a specific learning disorder in reading like dyslexia, about 30 to 45% of children also with ADHD are showing that need, and then also about 23.5% of children with autism also show. And so there's also difficulties with executive functions, as was previously mentioned. They can also have difficulties with sleep problems, so having difficulties going to sleep, staying asleep, insomnia, and language and communication challenges. But we're also seeing that both disorders can have co-occurring mood problems, though less frequently seen in early childhood. For example, about 16 to 17% of children with ADHD have diagnosed depression, where roughly about 7 to 8% of children with autism. So it's going to be important for early identification, and again, like anxiety, for screening. And so more of these mood disorders or mood concerns become more prevalent as children enter adolescence. When we're looking at autism, some that are more strongly associated with autism spectrum disorder is intellectual disability. So about 40% of children at age 8, according to the CDC, have an intellectual disability as well. This is much higher than children with ADHD, which most children have average intelligence. So an intellectual disability contributes greater support needs and is often identified via cognitive testing. There are also higher rates of neurological conditions like epilepsy or seizures in about 5% of children with autism. These are, though it seems 5%, this is actually higher than the general pediatric population. It's not currently or commonly associated with ADHD, and ADHD itself, when we're looking at autism and ADHD, estimates range that 50 to 70% of children with autism also show some symptoms of ADHD as well. And so we also have language delay and sensory processing concerns for autism as well. When we look at ADHD, here we have more of the behavioral conduct, oppositional defiant disorders. So things like ODD, right? Oppositional defiance is the most common comorbidity in ADHD. Roughly 1/3 to 1/2 of children with ADHD have a coexisting ODD diagnosis. And in contrast, ODD is relatively uncommon in ASD alone. Children with ADHD and oppositional defiance disorders often exhibit frequent temper loss, arguing with adults, refusal to comply with adults. They're also more severe with conduct disorder. And so here, this is involving a violation of societal rules and others' rights, aggression, property destruction. And this often emerges in older youth with ADHD, with studies indicating about 30% of children with ADHD might develop a conduct disorder later in life. In ASD, a true conduct disorder is rare, as social rule breaking in autism is usually unintentional and linked to social understanding deficits rather than delinquency. There's also higher odds of conditions like Tourette's or tics in children with ADHD, and some sleep difficulties related to insomnia as well. So when we're looking at therapeutic approaches, there are just a wide range of different approaches that can be helpful. And these are the ones that are usually seen most common, or the ones that we most often recommend. So the first for both would be behavioral therapy. So parent-focused training, coaching, especially in the younger years, as parents are the ones responding to behaviors, are the ones really setting up those contingencies early on. And so parent training, coaching, and also child-focused therapy would also be beneficial, especially as we see those mood concerns, and the comorbidities with things like anxiety and depression would also be very helpful. Applied behavior analysis is also highly recommended for children on the autism spectrum. Currently, insurances are only covering, medical insurance is only covering ABA for children on the spectrum. As a BCBA myself, I think it's very helpful for any condition here, but understanding that it's only accessible for a small subset of patients. And so ABA would be very helpful there. We also see social skills trainings here for children with ADHD, as well as children on the spectrum, how to navigate different social interactions and social support systems as well. Executive function coaching, this can be helpful for children with ADHD, as far as how to set up different understandings and how to help with planning, organization, regulation, things like that. As I mentioned, speech and communication delays are common in both diagnoses, and so speech language therapy and occupational therapy would also be very helpful. And medication is also one. Medication can be very helpful for children with ADHD. Um, Children with autism, where there isn't a medication that is geared for autism per se. However, many children on the spectrum will benefit from some medication if they have things like sleep difficulties or any of larger behavioral concerns as well. We will refer to pediatricians, or also to psychiatry should those concerns arise as well. And lastly, there's also educational and school-based interventions. So children with autism or children with ADHD, depending on their needs, could benefit from either an IEP, so special education, or a 504 plan. And so it really depends on how much support the child needs. And so if they are receiving an IEP, so they've been formally evaluated through a school district, they meet one of 13 IDEA disability categories, usually either autism or other health impairment, For children with ADHD, they'll receive specialized instruction, related therapy, supplementary aids. And so these children receive measurable annual goals with regular parent updates, parent and general. And so the team here meets yearly to create that plan. Versus a 504 plan, they're still meeting yearly, but it's more accommodation. So children with maybe less support needs might still benefit from a 504 plan as well. And so I hope that this was very helpful for you. I know I spoke really fast, and so just trying to make sure that I stay within the time allotted. And so I know there's questions, there's time for questions at the end, and so I'll be excited to hear some of those here soon.
Thank you, Dr. Amanya. Yes, there are Q&A questions. So if you'd like to go through those and respond in the box, or we can wait until the end of the presentation. Next, Laura, would you like to share your slides?
All right, give me a minute to share. Oh, it says someone else is sharing, so I think,
Yes, she already took those down, so I think you can
oh, let me
reshare.
try. All right, let me try again. Okay, now I can. Thank you, Gladys. You see my PowerPoint?
Yes, we do.
Okay, great. Let me put it in.
Yeah.
I'm going to make it bigger. Thanks. Well, hello, everybody, and thank you all for joining our webinar today. That was just so informative, what you just heard. And there's a lot of questions about, will this be recorded? Can we get the PowerPoint? And it will be recorded. I don't know about getting exactly the PowerPoint. I can share some of my slides, but we'll deal with that after the presentation. As Gladys told you when she was introducing me, my most important degree is my MOM degree. I should start my camera, shouldn't I? There we go. There. I really think my MOM degree is my most important degree. I'm the parent of he'll be 36 on the 4th of July, 36-year-old young man who was diagnosed when he was 3 months old with a rare genetic disease, of which autism is a part. And he's taught me more than any college degree ever could. You've heard, anytime we hear the word autism, you usually hear autism spectrum. And I think it's important to talk about.
Laura, you're breaking up.
I just saw a note that said my internet connection is unstable. Is it better?
Yes, it is.
Okay, hopefully it'll stay that way. It means that everybody's going to experience that condition differently. And we just heard Dr. Yamana explain that. It really depends on the person. And it depends on how the autism is expressed in each individual. So it moves us away from a rigid category. You know, there's some medical diagnoses, like let's say diabetes. You either have diabetes or you don't. But this is not the same way. You have autism, but it's a much broader spectrum of a description. And it avoids a one-size-fits-all label, which I think is really important, because working with people with autism does require much more personalized assessment and much more personalized forms of support. We see a lot of spectrum disorders. In the autism spectrum disorder category, a lot of people, I love this slide because you read at the top what people think the autism spectrum looks like. And they think it looks like that bar at the top. You're either less autistic, people have less autism, or they have more autism. Sometimes you hear people talking about lower functioning as opposed to higher functioning. All of those are very subjective terms and don't really tell us anything about who this child is, what the child needs, or what kind of supports are required, and where there are issues. So the graphic at the bottom of the slide, the circles with all the colors, really gives you a much better visual of what the autism spectrum can look like. And you could have really strong motor skills, but not so great executive functioning skills. Or, for my son has incredibly good expressive language. If you were talking to him, you wouldn't know immediately that there is any kind of an intellectual disability or autism, but his receptive language and his pragmatic language skills are very poor. So he doesn't always understand what people say to him the way they say it. He doesn't always perceive it the same way. There's a lot of misunderstanding there. And he does not read body language, facial expression, tone of voice. He doesn't read that at all. So that's a bigger area of deficit. But if you were only looking at expressive language, you would think there's no language issue. So I hope that gives you a better sense of what we mean by autism spectrum. And there are other spectrums. We talk about anxiety being a part of autism. Anxiety can have all these different words that describe anxiety. It can be tension, it can be restlessness, it can be nervousness. That's another form of anxiety, and again, a spectrum of symptoms. Mood disorders are the same way. This gives you a graphic of just what a mood disorder spectrum might look like, and how different it can look depending on the person again. In my own, I thought that was the next slide, sorry. ADHD, and that was mentioned earlier in the presentation, again, a spectrum disorder. And so one person's ADHD might look like the graphic on the left side, the other person's might look like the graphic on the right. It really is independent of and specific to the individual. My son has a disease called tuberous sclerosis complex. It's a rare genetic disease. He was diagnosed when he was 3 months old, and 36 years ago, they didn't have a gene marker for tuberous sclerosis. We call it TSC. So we went years not knowing even if we carried the gene. It turns out we don't carry the gene, but he got the disease. But they have now given a new diagnosis included in tuberous sclerosis called TAND, tuberous sclerosis complex associated neuropsychiatric disorders. It's that whole idea of co-occurring issues, right? And so under that umbrella of TAND, you could see any number of these symptoms. So for my son, it was really helpful for them to come out with this because we do have anxiety. He does have temper tantrums. He does have some language delay. He has academic difficulties with reading, writing, and spelling and math. He does have, he doesn't have an official label of autism, but he's got autism. It's under that umbrella. So it's, again, a spectrum disorder. And, with David's disease, I have known people who were so seriously impacted by the disease that they needed almost total support. But I've also met physicians who have the same disease. It's, again, a very wide spectrum. But here's the thing I think everybody needs to know and really get comfortable with. When you go to a geneticist or some other medical expert who gives your child a diagnosis, that is their job. And unfortunately, for those of us that have experienced that, their job is to paint the worst possible picture. They can't give you a diagnosis and paint a rosy, rose-colored glasses type of perspective, because it may not turn out that way. They have to tell you what could be. And that can be really discouraging, really dismaying. But the family's job is to become an expert on who this child is. Who is this child outside of the diagnosis? Who is this child with the diagnosis and how this particular child is impacted? And more importantly, to believe in what's possible for this child, to have hope for this child and his or her future. We were told when my son was diagnosed at 3 months, he would likely never walk or talk. He's at work today. He drove his own Ford F-150 that he bought with money he earned. So they were wrong. We can't, they don't have a crystal ball. Like I said, their job is to paint the worst possible picture. So you're prepared for what could be. But your job as family and people who are supporting families is to have hope and belief in what this child can do. And I want to encourage everyone to remember that a disability label is nothing more than a medical diagnosis. It is not the sum total of who this child is. Unfortunately, a lot of times we end up feeling like that is who our child is because, as a young parent with a 3-month-old baby, the only people we were seeing were medical specialists, therapists, educators, and that was all they talked about was the diagnosis and what the child couldn't do, what he might never do. It can be very discouraging. I encourage families to remember that their child's diagnosis is nothing more than a medical diagnosis. You have to get that diagnosis, it has to come from a medical professional. You can't just decide your child has autism. It comes from a medical professional. And so it's a medical diagnosis. And the only time you need that medical diagnosis is when you need a specific type of service. So, for example, Dr. Yamada talked about special education or Section 504 services. You would need a medical diagnosis to qualify for those services. That's when you get your passport out. I think of our diagnosis as a passport to services. I live in East Texas. I'm like an hour from Shreveport, Louisiana. I don't need to get my passport out to drive over to Shreveport and cross the state line. But if I'm leaving the country and I want to come back in, I would need a passport, right? It's the same way with our child's diagnosis. And this is what professionals can really help families get comfortable with. I've met families who they want to hand out cards at the grocery store saying, my child has autism, learn more about it here. And they tell me what's important for people to understand the diagnosis. And I agree with that, but never at your child's expense. If you are passing things out at the grocery store or Walmart about your child and your child is standing there hearing you talk about it, what are you doing that could form that child's opinion and understanding of himself or herself? So I really encourage people to only pull out their disability label passport when they need to open a door to services. If you need to qualify for Social Security services, you're going to need a passport, or you're going to need that diagnosis. If you need to get into a specific medical clinic or hospital, you're likely going to need that medical diagnosis passport. Again, for special education services, you're going to have that medical diagnosis passport. But any other time, put it in your back pocket. William James, back in the day, said the greatest discovery of my generation, that was his generation, is that human beings can alter their lives by altering their attitudes of mind. And that was really true in our life. Like I said, my son diagnosed at 3 months of age and given a very grim prognosis of what could happen, what his life might be. But we were so fortunate to have a pediatric neurologist who made the diagnosis. And he said words I've never forgotten. And he changed our life and he changed our son's life with these very words. He said, this child will be as disabled as you choose to see him. This child will be as disabled as you choose to see him. And so I can tell you, we're almost 36 years into this journey. And my husband have for years asked ourselves, okay, is this typical 12-year-old behavior, or is this 12-year-old behavior exacerbated by the diagnosis? That was usually the case. Instead of it just being, this is because of this diagnosis, this is who he is. It was usually the diagnosis was a piece of what we were seeing, but there was so much more to him outside of that diagnosis. We have to make choices about how we see the child and who they are with the diagnosis and outside of the diagnosis. So this is what I tell every professional working with families who have a child likely to get a medical diagnosis like this. Get them on the Medicaid waiver list immediately. I gave you a link in this slide, and we can include it in the handout. Navigate Life Texas is a really good website, and they have a perfect page where a parent video explains Medicaid waivers in parent-friendly language, because no offense to HHSC, but sometimes their website is a little difficult for families who have no clue what they're talking about. But a Medicaid waiver, every state has Medicaid waivers. They haven't always been around. They really came around in the early 1980s when people who had disabilities, adults we're talking about, the only place that they could receive services was in nursing facilities, institutional care. And a lady named Katie Beckett said, why do I have to be here to get services that I need when I could get those same services at my house and be a much healthier person? And it evolved into what they call the Katie Beckett waivers. We don't call them that much anymore. Now we call them Medicaid waivers. But there's a series of different programs that a child can qualify for based on a disability label. Unfortunately, in Texas, we have a very long wait list. Some states don't have wait lists, but we have a very long wait list. Our list is over, and the state does not call it a wait list. They call it an interest list. But pardon me, we have over 100,000 people on that list. And the typical wait for Medicaid waiver services is 12 to 18 years. So you can't afford to wait. Pardon me, you can't afford to wait until your child's 15 or 16 and then decide, gosh, I think he's going to need some services as an adult, because you're 12 to 18 years behind the 8 ball. So I encourage providers and people working with families to get that child's name on the list immediately. For services. You don't have to prove. I'm sorry, what? I thought somebody said something to me. There's talking.
You're breaking up a little bit.
Okay, it said unstable again. Sorry. I don't know how to fix that. When you are adding a child's name to the interest list, hold on a minute. Pardon me, allergies. You don't have to prove that this child's going to qualify for the program. You don't even have to know what services the child is going to need or what program they might best qualify for. You just get them on the list. The only thing you'll be asked when you're putting a child's name on the list is the child's name, their date of birth, their social security number, and a brief questionnaire. You'll be given an ID number. I encourage families, don't lose that number, because that's how they keep up with you. And if your name comes off the list, that's how they're going to reach you. You can use that ID number on a website called yourtexasbenefits.com. It's a way to update your information. If you change your contact information in any way, you move, you get a new cell phone number, you want to update your information at yourtexasbenefits.com, because to the bottom of the list, or it just drops off the list. So you want to keep Health and Human Services abreast of any contact information that you have changed. On the wait list, where you go for what services, etc. And what I tell sitting here telling them this like I'm telling you now, it's going to go in one ear and out the other, especially when there is a very new diagnosis. Their heads are reeling. I even those calls because it might get lost in the midst of everything else that's going on with this child's life. Them. It's easy. It just takes 5 to 10 minutes at most. And then remind them they have to keep that information updated annually. Once your name is at the top of the list, you'll have 2 options. You'll have to complete a Medicaid application. It's either a paper form or you can complete the application online at the website I mentioned earlier, yourtexasbenefits.com. You'll have to set up an account and then submit an application for new benefits. And we'll include this in the handouts that go out. Bottom line, what my message is to you all today is, in spite of what can be a very scary diagnosis, especially when you're a brand new parent or have a young child that is help them cultivate hope. If your whole life all of a sudden becomes about medical professionals, therapy professionals, education professionals, and all of those people are really good people who are really good at what they do, but their job is to focus on the deficit. What be a very discouraging thing that over time can really influence how you see the child. You lose sight of who the child is because all you can see is the deficits. We want to cultivate hope. This child has lots of hope. Like I said, my son we were told he'd never walk or talk. He drove himself to work this morning. So you don't know what the future holds. And technology is changing lives incredibly, that we couldn't have expected. My son's autism certainly impacts his ability to write and read well. But now we have voice to text. You can just tell Siri what you want to say and she types it out. Or you can tell Siri to read it to you and she does. Technology is changing dramatically. Who imagined, I grew up in the day when you had to know how to count change. Good luck finding a cashier at a register now who knows how to count change, because we don't do it anymore. We use calculators. We have calculators on our telephones. We don't know what the future holds for any child, but hope is the key to a positive outcome. And this is my contact information. If there are questions that I didn't answer in this presentation or you wanted to check with me later, I welcome your email. And I'll turn it back to you, Gladys, to answer some of the questions I know came in. I'll stop sharing.
Thank you, Laura.
Thanks.
So one of the questions we have is, can a child without a Social Security number be placed on this Medicaid waiver list?
I don't believe you can. Don't quote me on that. I'm not an HHSC expert, but I don't think you can.
Okay. And then the next one is LPC credits. Laura, I think you mentioned something about that.
I'm an LPC myself, and at the University of Texas, we're authorized to give LPC credit, so yes.
Okay, so then we will send out that information as well. It says, Miguel, I believe, yes, go ahead and call the LIDDAS or HHSC line. So, okay. Sounds like someone answered that one. Thank you. Okay. And any other questions? Please put them in the chat. Is there any other information, Dr. Umania or Laura, that y'all would like to share?
Well, I know there were some questions that I thought maybe Dr. Umania could address. I'd have to look back to see what the questions were.
Yes, she was very active in the Q&A box.
Oh, good. Okay. Yeah, there were some questions about how do we help with this issue or with that issue. And that's a valid question. I can remember a speech therapist working with my son when he was very young, and language was really difficult for him to achieve. And he began, I mean, it was years before he could express in a complete sentence. But so he would begin with maybe 2 words. He might say yellow cup, and the speech therapist would instruct us to say, I would like that yellow cup, to say what he's saying in a complete sentence, because we're modeling for him. And I encourage people to do that even now. Model what you're trying to help this child learn, model it yourself. I'm sure Dr. Yamana, you have other things to add.
Yes, so my recommendation for the question was the use of alternative or augmentative communication.
Absolutely.
So
Thank
things
you.
like picture exchanges, which would be low tech. Sometimes it's switches, right? One or two communication, yes or no, depending on the verbal ability of the child, and also receptive language, or things that are higher tech and like use of iPads and different apps that they now have as well. And so speaking to a speech therapist would be recommended. And then also understanding that this could serve as a stepping stone for communication later. So what I like to tell parents is to try them and to understand that it's giving the child or the individual a voice. And so that way they can hopefully, right, the goal might be for verbal communication as well. But we just want communication so that they're able to share as well.
Boy, I applaud that answer. I've met so many parents who are fearful of using augmentative communication because they are afraid that their child will never speak if they use that. But the reality is, the child's going to be very, very frustrated if they have something to say and don't have a way to say it. And that's when we start to see some real behavioral challenges. I've met too many kids who are well into their, close to 8 and 10 years old and have no means of communication, and they communicate with their behavior. So I applaud that answer, augmentative communication, as soon as you know there's an issue. Yeah.
We have another question that says, what resource would you recommend for parents reading, like parenting books, etc.?
For parents reading,
Yes.
I don't know of any specific book, but I'd just read out loud all the time. Every chance you got, read out loud with the child. Modeling again.
Okay, and then thoughts on the autism database our politicians were attempting to create in April, May, maybe how to help protect our clients from what may change in the future.
I'm not sure I understand the question. Can you say it again, Gladys?
Yeah, it's just so hard. Let me go back and find it. Thoughts on the autism database our politicians were attempting to create in April, May, maybe how to help protect our clients for what may change in the future.
I don't have an easy answer for that. There's a lot ahead of us that we don't know what exactly to anticipate yet.
Yeah, Melissa, if you have any clarifying thoughts, you can type it into the Q&A box. Let's see, what else? Any tips on helping individuals that are on the cusp of the diagnosis?
I think providing recommendations that would be given, especially if they're at that cusp, giving any recommendations that would be helpful. Just because you don't meet the criteria or full criteria doesn't mean that recommendations wouldn't be helpful for them as well. And so we're putting maybe a name on the symptoms, but if there's symptoms alone, then still validating those and understanding that those are still maybe areas of difficulties or challenges for them. And so any recommendations that would be provided to individuals who have received maybe a formal diagnosis might still be helpful for them. And then
Some of the best advice I can give to any family either on the cusp or with a full-blown diagnosis is to find other parents who are on the same road you're on. Texas Parent to Parent is an excellent nonprofit organization here in the state of Texas. And they can even match you up with other parents who have a child with a similar diagnosis. Those parents are trained. They're not just parents who say, I'll talk to anybody. You get somebody who has a clue. And, you know, I always say the best experts will come and speak, or the Social Security expert. My internet connection's unstable again. The Medicaid expert will speak, or Social Security expert will speak, and they're wonderful. They're knowledgeable. But they'll hand out their brochures, but they don't stay up until 3 o'clock in the morning trying to figure out how to fill out their forms. And I've done that. So if you can find a family member who's on a similar journey and with a similar diagnosis, they're going to know things that your typical experts are not always going to know, because they've had to find out the hard way and through a lot of experience. And they're great support. They can be very encouraging.
For the next question for Dr. Umania, when you mentioned 50 to 70% of children with ASD show ADHD symptoms, is this an indication for evaluation for a full ADHD assessment, or for this client, or simply a common overlap in similar symptoms?
So that was a statistic where it was showing that 50 to 70% of children with ASD might also have an ADHD diagnosis. I was just typing that answer. So that in a full evaluation for autism, ADHD should have also been a rule out. So it shouldn't need a separate evaluation if the evaluation initially was comprehensive. Now, if it was early on, so we see children right at 2, 3, 4, where ADHD might not be indicated for diagnosing yet. That's usually around 5 or 6 where we start to kind of really consider that might warrant talking to that provider and bringing that up again with pediatrician at that time.
So next one was, I wrote my question wrong. I was asking for resources for parents to read to help their child, like parenting books, not books to read to their kids.
Yes, I can put some in there.
As a teacher, how can I help students with autism and ADHD in the classroom?
So this would, like I mentioned earlier with the question, depend on the child and the individual needs of each child. And so I think providing movement breaks, providing alternative seating, right? So we've been seeing that a lot in elementary classrooms here, where maybe they can sit on a yoga ball or they can stand up and just have alternative seating, some movement breaks, some maybe quiet down spaces, reminders and check-ins with them as well. Also having different, I think, education regarding to other children as well. So providing them with information about differences within childhood, just to start to develop some of that empathy and understanding related to differences within peers, as I think is important as well.
And predictability, helping the child know what comes next and what comes after that, and so that they can anticipate and be prepared for. A lot of our kids don't do well with surprises, or transitions are difficult. My son's ability to transition when he was young was not expecting. We usually need to prepare for about 15 minutes for him to be able to make that transition in his head. But I think predictability is a real key for a lot of kids. There's some great questions here, y'all.
Yeah, very great questions. But we are running out of time. So I did ask Chris, our IT person, if we will have these questions recorded, and we will. So I'll share those with Laura and Dr. Umanya, and we can answer those in upcoming emails. So, but for now, I think we'll get to the conclusion. Let's see.
Well, I'll just say in closing, if you're for what you do, because as a family member who relied on a lot of professionals in our days, you provide a critical and much needed resource and very much appreciated.
And I apologize for the noise. I am in a shared space right now. Well, thank you very much. And once again, we're grateful for your time and for everybody's participation in today's webinar. If you're viewing live today, you will receive an email with survey links for both social work and nursing and information from LPC that I'll get from Laura. And this will need to be completed to receive credit. The email should be in your inbox later today or tomorrow. Once the survey is completed, you will receive a certificate of completion within a day or two. However, if you're viewing this as a recorded version of the webinar, this session is not eligible to receive CEUs from the recording. If you have any questions about this session, then please feel free to email me, Gladys Pryor, at gladys.pryor@bcm.edu. Our next webinar in this series is titled The Basics of Genetics Testing for Young Children with Congenital Heart Diseases, and will be presented by Emily Solsick, a certified genetic counselor with Baylor College of Medicine and Texas Children's Hospital. And Laura Buckner will also be there as our second presenter. This session is scheduled for Wednesday, July 9th at noon. A registration link for this upcoming webinar will also be included in the same email containing the information about the surveys. And we hope you can join us for that future session. Once again, thank you very much for your time. And this concludes today's webinar. Have a great afternoon. Thank you so
Thank y'all.
much.